Hello, welcome to the presentation of my case study, Enhancing Function Through Individualized Physical Therapy in a 56-year-old female with Guillain-Barre syndrome, a case study. My name is Sarah Doss, student physical therapist, and my mentor is Dr. Elizabeth Billeter. To share a background on Guillain-Barre syndrome, GBS is a rare immune-mediated acute polyradiculopathy with a wide variety of musculoskeletal and neurological symptoms. This means that the nervous system attacks itself, primarily the myelin sheaths of peripheral nerves, resulting in extreme weakness. This then results in weakness and neurological symptoms. The clinical presentation of GBS widely varies from patient to patient. The most common symptom is progressive muscle weakness that starts distally and moves proximally. Most patients report weakness beginning in their hands and feet that then moves towards the trunk. Occasionally, the facial, axial, and respiratory muscles are affected. Sensory impairments may include pain or nerve symptoms such as a tingling sensation. And some patients experience autonomic impairment such as dizziness or lightheadedness, increased heart rate, nausea, or vomiting. Here we have an image that is comparing a normal nerve on the top to a nerve that has been affected by GBS. You'll see how the affected nerve's myelin sheath has been damaged, leading to the nerve fiber itself being exposed. This results in that peripheral weakness and oftentimes that tingling or pain symptoms. Most GBS cases are triggered by an infection of a bacterial or viral source. Some patients have reported the onset of symptoms following a vaccine that caused an autoimmune response. In cases that are caused with a bacterial source, Campylobacter jejuni, is the most common type of infection, whereas in viral infections, cytomegalovirus, Zika virus, and COVID are the most common. Let's talk about some statistics of GBS. The incidence of GBS is actually quite rare. Males are typically more diagnosed than females, and patients of all ages, ranging from infancy to the elderly, have been diagnosed. GBS typically has a very positive outcome regarding recovery. Most patients recover back to their baseline of function that they had prior to the onset of symptoms. Only 10 to 20% of patients have residual disabilities that impact their function long-term. Indicators of prognosis include age of onset, presence of bulbar weakness, degree and progression of motor weakness, and the need for mechanical ventilation. How is GBS diagnosed? There is no specific diagnostic criteria for this syndrome. This is due to the large variety of clinical presentations and symptoms across the patient population. To diagnose GBS, many other neurological conditions must be ruled out. Common tests that are done to rule out other diagnoses include neurological exams, cerebral spinal fluid testing, electrophysiology studies, and MRI imaging. We do have the Brighton criteria, which has been developed as an assisted tool for diagnosing GBS. It assesses muscle weakness that has no known cause, bilateral flaccid weakness, and decreased tendon reflexes, and the results of electrophysiology studies. The clinical research on GBS and physical therapy treatment is extremely limited. This could be due to a multitude of factors, such as the large variability of symptoms for each patient. The diagnostic process of diagnosing GBS also requires the exclusion of other conditions. And since these patients typically recover back to their baseline, this shortens the window of opportunity for research compared to other neurological conditions. The purpose of my case study. The purpose of this case study is to discuss the benefit of individualized physical therapy, including energy conservation training on functional recovery for patients with GBS, while also highlighting the lack of research regarding physical therapy care for this patient population. So let's talk about our patient. The patient is a 56-year-old female referred to outpatient physical therapy with a referral that listed the following diagnoses: Guillain-Barre syndrome, multiple sclerosis, and myositis. Please take note of the multiple and very diverse diagnoses. When we started the evaluation, my clinical instructor and I asked the patient about this. A patient verbally declined knowing about GBS and MS and stated she had only been aware of the diagnosis of myositis. So let's walk through a timeline of this patient's care. 4 months prior to the physical therapy evaluation, patient had a neurology appointment for symptoms of headaches, mild vertigo, blurry vision, and weakness. At this visit, her neurologist sent her straight to the hospital, so we have our first hospitalization. She was only there for a short time before she was discharged. 2 months later, she had been home for quite some time. Then she had an onset of ataxia and a worsening of symptoms. This led to our second hospitalization. Our PT evaluation then occurred. The proposed plan of care was 2 times a week for 12 weeks. The patient was seen for a total of 10 treatment sessions with a reevaluation conducted on the 8th visit. Now, here is where things get a little bit interesting. Remember how I mentioned that the patient didn't know about her diagnosis of GBS? Well, at approximately the 6th visit, patient came into her treatment session and reported she had a follow-up with her neurologist, who did indeed confirm the diagnosis of GBS. The patient's care also continued after the conclusion of my clinical rotation. So let's talk about the exam. At the initial evaluation, the patient's chief complaint were upper and lower extremity weakness, with the right side of her body affected more than the left. She was reporting abnormal sensations in her legs and hands, decreased sensation and coordination in both hands, and she reported jerky movements in her feet. Her activity limitation and participation restrictions included walking long distances, standing up from a chair, navigating stairs, dressing independently, and performing housework. She was also unable to work or participate in recreational activities at this time. Aggravating factors were included to be overexertion. Patient lives with her daughter in a 3-story home with her bedroom on the upper floor. Prior to the onset of weakness or any other symptoms, she had been completely independent with all ADLs and was very physically active. For occupation, the patient works in finance management, and typically she works from home. But at the time of the evaluation, she had been on medical leave since her second hospitalization. Her patient goals established at the evaluation included navigating stairs safely, decreasing her fear of falling, increasing strength, and wanting to be able to ambulate safely. Here we have an overview of the examination findings. So on the sensory exam, the patient had abnormal light touch sensation in both hands, bilateral adductors, and the right lateral leg. And she also verbally reported that she would have numbness in her feet after walking. That was not present at the time of the evaluation, but it was a subjective report. For manual muscle testing, she presented with bilateral lower extremity weakness in hip flexion, hip adduction, and hip abduction, with scores ranging from -2 to +3 out of 5. Her grip strength was impaired with a difference of 38 pounds between the left and right side. And she had impaired balance that was demonstrated via testing on the modified sit-sib, where she had increased postural sway and ankle sway in all 4 testing conditions. While my CI and I had planned to assess the 5-time sit-to-stand test, we were unable to do so at the time of the evaluation. This was because the patient required maximum assistance to transfer from the chair to the plinth table. For some clinical impressions, the primary impairments were noted to be significant global muscle weakness, decreased balance and stability, and decreased endurance. These impairments had limited her from feeling safe with community ambulation, navigating stairs, and standing up from a low surface. The proposed plan of care for physical therapy was 2 times a week for 12 weeks. Skilled interventions were recommended to improve balance, function, neuromotor control, strength, and decrease the patient's fear of falling. The treating therapist also recommended that the patient obtain a single-point cane for safer community ambulation. So the interventions that we used, we're going to go through them on the next few slides, but we used therapeutic exercise, therapeutic activities, neuromuscular re-education, and a lot of patient education. So here on this slide, we have the exercise in the first column, the initial parameters, and the progression that we achieved. To start with, we did aerobic conditioning via the upper extremity and lower extremity combination bike. We did a range of 6 to 10 minutes, resistance level 1 to 2, and this was largely depending on the patient's fatigue and how she felt that day. The bike was a great opportunity for the patient and I to discuss her conserving her energy and learning to understand where her body was at and what it was able to do on each day. We also did some seated boxing punches on an RX pad, which we were able to progress from 3 sets of 15 seconds to 3 sets of 30. For hand strengthening, we did some resistive putty squeezes and also isolating pennies out of that resistive putty. Those were progressed by using a stronger putty resistance. For lower extremity, we did a wide variety of exercises, including hip abduction, isometrics that progressed to side-lying clamshells, isometric hip adduction. We did long arc quads. Those were able to increase in sets and eventually added weight. We did seated hamstring curls, also increased sets and added the resistance band. And we did a lot of sit to stands starting with upper extremity support and at a 24 inches height table. We were only able to start with 2 sets of 8 repetitions at the first initiation of this intervention. Eventually, we were able to increase the repetitions, and then we did a variety of progressions from lowering the table height to not using arms to then using a partial sit to stand with a 5-second hover over the table. We also did a lot of balance activities from tandem balance to single leg taps with the blaze pods, using the hurdle steps, and also doing like a modified, almost like a Captain Morgan pose with one foot up on a stool while she did blaze pod activities. And some of the functional activities that we did included forward step ups for navigating stairs and gait training and assistive device training. One of the key factors in this patient's care was patient education. Given the neurologically driven factors of Guillain-Barre syndrome, the treating therapist spent a lot of time discussing energy conservation techniques with the patient. While GPS differs from conditions like MS, there are principles of care that can be applied across both patient populations. I educated the patient on the principle of the 4 Ps for energy conservation, including prioritize, planning, pacing, and position. Verbal education and written handouts were provided to the patient. Now to talk about some outcome measures and our reevaluation. So the reevaluation was conducted on the 8th treatment session. And here we have the patient-reported outcome measures, which are, they were filled out like either on paper or on a tablet. And we have the MDQ and the NDI were assessed for the patient-reported outcome measures. So you can see here the MDQ, the patient initially rated a 38, and then at the reevaluation had a score of 48. This is a change of plus 10, and this is actually demonstrating an increase in disability. The NDI, which was originally rated at a 30, maintained that score, demonstrating no change. It is important to note, and we'll talk about this a little bit more in the discussion, that while the patient did not demonstrate a change in function on the NDI and actually an increase in disability on the MDQ, her subjective reports were still showing that her function in daily life had improved. Here's some more objective findings at that 5-week reevaluation. The patient specifically demonstrated improvements in lower extremity strength, grip strength, and performance of the 5-time sit-to-stand assessment. So you can see that sensory exam, we had improved light touch sensation in the lower extremities. There was no difference between the left and right side. Still had a little bit of numbness persistent in her feet with any exertion. Global MMT scores increased bilaterally to greater or equal to of 3- out of 5. And remember, we had originally started at a 2-. Grip strength increased bilaterally with the left now equal to that of the right. Balance, important to note, it had been improving prior to this reevaluation visit, but we completed the balance testing towards the end of this session and the patient was quite fatigued. And then we were able to do the 5 times sit to stand, in which she achieved 3 repetitions in 35 seconds. So for subjective outcomes, subjectively, the patient reported improvements with ADLs and functions at home, like navigating stairs and being able to dress independently. At the time, she had returned to working part-time, but was still felt extremely limited by fatigue. The patient noted she still felt limited with stairs, but was more confident ambulating longer distances because she was no longer afraid of falling. While the patient reported outcome measures, as discussed a few slides prior, displayed a decline in status, the patient verbally reported improvements in functional activities, including mobility, ambulation, transfers, and ADLs. So, despite the lack of objective data to demonstrate progress, the patient's subjective reports and her ability to return to functional activities, including working part-time, continue to support the benefits of individualized physical therapy interventions for patients with GBS. Individualized physical therapy is highly beneficial for this patient population to improve their function, but there's so little research to guide patients. In my search for research to back intervention ideas for this patient, I only could find one randomized control trial that focused on physical therapy interventions for patients with GBS. Again, this could be due to the rarity of GBS, like we discussed earlier. It's harder to access this patient population compared to others, but still, our patients require the same amount of dedication. So the subjective patient report of her ability to return to work and function demonstrated that positive impact of patient education on symptom management and implementing energy conservation techniques. So for some implications for practice, patients with GBS will greatly benefit from individualized physical therapy that focuses on the individual's specific impairments. This case study does serve as an appeal for more research to be conducted in order to identify interventions that would be more successful for these patients. There is a carryover of intervention principles from MS to GBS, such as those energy conservation techniques, muscle strengthening, and functional activity training. But however, this does a disservice to patients with Guillain-Barre syndrome that deserve the same amount of dedication and research. I'd like to highlight some limitations of this case study. At the beginning of this patient's care, the therapist should have reached out, meaning myself and my clinical instructor, should have reached out to the neurologist and inquired about those multiple diagnoses on the referral. If we had been able to get an answer about the diagnosis of Guillain-Barre syndrome sooner, this would have allowed for more educated clinical reasoning for this patient's care. Additionally, it would have been more beneficial to administer patient report outcomes that are much more specific for patients with neurological conditions like GBS. The MDQ and the NDI that we used showed to be really not relevant for this patient's impairments and therefore did not provide us with quantitative data regarding her progress over time. And finally, our patient was only able to attend physical therapy about once a week rather than the proposed plan of care of twice a week. This was due to her own limitations and needing to use a rideshare for transportation. During the last week of my rotation, I did kind of put the bug in the patient's ear about her reaching out to her insurance company and seeing if there were any opportunities for her to get assistance with transportation to physical therapy. I'd like to express some gratitude. I want to first thank Dr. Billeter, my mentor throughout this process. I greatly appreciate the time that you have invested in me and this presentation. I also want to express gratitude to the subject of this case report. In addition to allowing me to share her story, she had shared the results of many of her medical tests with me, which provided a more in-depth context for me. I also want to thank my clinical instructor from this rotation for allowing me to try intervention ideas and trusting me with patient education. And finally, thank you to everyone who attended my presentation this morning. I appreciate your time and attention. Here are my references, slide 1 and slide 2. And now we have time for any questions. Thank you so much.